stuff. It's for public consumption. You okay with that?
Sure. Yep.
Okay. And you know, I'm a doctor, but I'm not your doctor. There's
Right.
yeah, you
There's
have
a
to
difference.
there is. All right. Well, tell me about you. What's going on with you?
Okay, so I'm in about my 9th week or so of right leg pain. I went to my primary care doctor a few weeks into it and said my leg hurts. We thought at first, we thought, okay, let's check out PAD because I have had a heart stent put in, and I'm thinking, worried to death about PAD. None of the symptoms were matching up to PAD, however.
Hmm.
And I'm thinking, okay, that's not the route, and thank goodness.
Yeah.
But he kind of left it undiagnosed. He said, we don't know what it is. And I said,
Hmm.
well, it hurts and it's getting worse. So I called back and said, okay, we got to do an MRI. I want to find out because to me, this seems like a back related issue. We did an MRI. And based on the MRI on May the 19th, he refers me to a orthopedic surgeon, which scares me to death because I'm thinking, okay, wait a minute. I think there's more to this than just me going to orthopedic surgeon. I did my research and I found out that after, well, actually from you, that after, so many weeks, 6 weeks or whatever, 84% of people with this
Mhm.
issue resolve after 12 weeks, 90 something percent. So
Right.
it's okay, the body can heal. Okay. Let's be sure I'm right in the right situation to heal. So as far as lifestyle, I right now am not doing any lifting. I stopped my exercising other than PT. So I'm not doing anything to re-injure. Okay. Uh, I took 7 treatments of chiropractic treatments, and they were the more aggressive, crack your neck off your head type things until I did my research and found out that is not a good thing to be doing
Right.
because I was getting worse and that could make it a lot worse. I stopped doing that. And now I'm on my 4th session of PT. And generally speaking, I feel like there's light at the end of the tunnel, things will get better.
Oh, good.
So, in a seated position during the day, I typically don't get over level 1 or 2. Sleeping at night is typically okay. I'll have to take something to help me sleep sometimes. I usually go to bed with the ice on my back and put it on a timer.
Yeah.
And then I can sleep through the night. If I walk for over, say, just around the house is pretty much all the walking I'm doing now because I have my groceries delivered. I got somebody mowing my grass so that I'm not doing anything that pushes it. Around the house, if I walked around the house for a while, I could get up. Last night, I don't know why, but I got up to level, 6 or 7 walking around the house. It made me so mad. If I
Hmm.
were to walk 500 feet, beyond that point, I would start getting to a level 9-ish where I stop every 3 steps. Memorial Day, I had to walk a couple of blocks. I was stopping not by choice, but I had to stop every 3 steps, let the pain resolve, and then in tears, walk forward, you know, hoping that I'm not really doing something bad to myself trying to walk these couple of blocks. Prior to all this happening, I walked 3 miles a day with the right shoes. I was lifting some weights using a Bowflex machine, strength resistance thing, probably lifting more at the age of a 45 or 50-year-old than a 70-year-old, but I don't think that was a problem. Got a Pilates reformer in the basement, and I use that a couple of times a week usually. So I'm doing all those type things. In the last year and a half, I've lost 30 pounds. I'm
Hmm.
a vegan lifestyle diet with the exception of mozzarella cheese on a pizza once a week. I cannot resist. Otherwise, I'm good. No meats, nothing like that. So I'm saying, okay, I'm doing the right things. Except
Yeah.
I think I did do one wrong thing, and that was at a band practice one day and said, "Can you come over here and help us lift this guy, help him get to his walker because he's disabled?" And oh yeah. And I lift sideways, take a lot of his weight. I don't get a pop, nothing happens right away, but all of a sudden after that, I started getting this leg soreness in the days and weeks to come. So, so it's all in my right leg, from above the knee, on the inside of the leg up to my thigh. I got the names of the muscles written down, but Lord help me if I can pronounce them properly. But you get the idea. Sometimes it'll be really bad right above the knee, not in the knee. And sometimes it'll be more up into, not the groin area, but right to below that, so the thigh. Occasionally get over to the right glutes, but usually in the leg there. Nothing in the left leg. I have no changes between the legs otherwise in terms of discoloration, hair loss, ulcers, anything like that. And I have no back pain. And I hate pain.
Yeah. Good.
And so I know, I feel confident after the research I've done that I should maximize the conservative approach that I'm on. I am taking a course through the Phoenix Spine and Joint Clinic. I don't live there, so it's online. Through a doctor, I've checked his accreditations. I'm very well convinced, yeah, he's the guy I need to be working with, strengthening abs and glutes to help support back health.
Mm-hmm.
And I'm only in my fourth treatment of that, so there's time to heal. I'm convinced the body will heal itself if I allow it the room to do so. So I guess my goals today are, and then I had a real big concern. And this is what really led me to saying, okay, wait a minute, panic. Number one, I'm not a doctor. I cannot diagnose these things. I've looked at the MRI results and everything, and that'll scare you to death if you don't have any idea what you're looking at. But I'm thinking, okay, oh my gosh, I'm starting to be constipated for a few days. And after I go, I feel like some urge, like I still need to go. What's going on? I'm a vegan. I don't even know what constipation is,
Yeah. Yeah.
I started to get concerned. Well, then I considered it. I looked at the MRI scan results again. I said, well, it's not really in the areas where issues of incontinence is common, but it could impact that potentially. But also noted the prescription drug I was taking for anxiety, not really directly for pain relief, that I've only been taking for the last 4 or 5 days because of anxiety caused by taking the what's the steroid you take? Prednisone. I never can say that right.
Prednisone?
Yes, thank you.
Okay.
And that made me anxious, so I took something prescription, Xanax, for that.
Mm-hmm.
Well, you know what? That can also cause mild constipation. And it's summer outside. Maybe I'm not drinking enough water. So that part is resolved. I'm not feeling incontinence. I don't have symptoms of incontinence. There's no numbness. The only thing there was a bit of panic. And you know what? I need to find, I don't need to wait another month or two before I see orthopedic surgeon or somebody to say what I should have been doing or should be doing. So I want to maximize the conservative treatment, minimize the possibility of having to take injections for the pain, but we'll do it if I need to down the road. And I know there's different surgical options, but and I've already got doctors picked out, but I don't think I'm going to need to get there. So that's why I'm here.
Got it. Can I ask you some clarifying questions? I understand that you have, basically, if I could recap, you have a 9-week history of, for the first time, right leg pain, which I would refer to as being in the L3 distribution. So it starts a little bit in the back, but mostly goes from the groin to the inner part of the thigh. I assume you have a little bit of numbness there on your inner thigh.
No numbness.
Okay, that's good news. And is there any weakness in your quad? If you bend your, could you, for example, if you stood just on your right leg and tried to do a single leg squat, is that as strong as your left leg, or can you tell?
No weakness.
No weakness. Okay.
Okay.
So what we just have is a sensory radiculopathy, which means radiating pain in the right L3 distribution of 9 weeks duration, with some questionable symptoms of bowel problems. And don't let me forget, we'll go over that together, whether we'll look at whether or not that relates to your back. Spoiler alert, it does not. So, but we'll go over that to give you a little more reassurance here in a second. All right. You've done a great what kind of work do you do? You're a great historian. Are you a historian or something?
No, I just had 40 years with a Fortune 100 company and persevered and worked hard and became a specialist at whatever I needed to become a specialist at. And
Yeah,
I've
very
learned
adaptive intelligence and very detail oriented. Well, anyway, thank you very much for that history. It's a big help. I honestly don't have much else to go through. So if it's okay with you, I think we should just turn to the MRI, if that's all right.
Absolutely.
All right, give me a second to get that pulled up. Yes, I'm very excited to be using a new software package for MRI, which I'm kind of in love with.
Cool.
Okay, this is your MRI. John Bowman Spalding?
That's correct.
My wife's maiden name is Bowman, so I saw that one right away. All right, this is your MRI, and we've got two views here.
Yeah.
In this view, we're right down the middle of you. This is your spinal canal, called the sagittal view. And in this view, we're perpendicular. And this image here, the blue lines, they show us the slice that we're looking at over here.
Okay. Oh,
Does that make sense?
it sure does.
And you haven't had surgery.
Correct.
Yeah, I mean, your chiropractic was way too rough. The ligaments between the spinous processes are all swollen, as if you've had some kind of an injury. So I really think whatever was going on there was way too much for your back, and I'm glad you discontinued it. Your underlying problem, if you look right down the middle of your spinal canal, it's great, it's perfect. And the bones are good. And thanks, Mom and Dad, you have very nice discs for your age. All of that is very, very good. But if we get off the midline and look here at the above the L3-4 level, we see a nice, beautiful, healthy, normal spinal canal. But as we come down to the L3-4 level, we get this kind of steer's head with the ears approach. That's mild to moderate stenosis. But as you go out on the right side, there is significant narrowing, and it's hard to tell, but I think there's a herniated disc fragment out here. Let me go out there and look. Yeah, so there's a lateral recessed disc herniation on the right side right there.
Yeah.
It's a little bit, take my word for this, but let me show you. So the normal foramen, the hole the disc comes out, looks like this. There's three things in the foramen. There's a nerve, an artery, and fat. And the whole thing normally has the shape of kind of a weird comma with a kind of a yin yang sign in it. See that?
Yeah, I sure do. Yeah.
Now, if we look at that here, we're not seeing it because we're at the wrong cut. The cut doesn't go right through it. But if you look at that here, this thing shouldn't be there. This is disc fragment that is pushing the foramen, pushing out into the foramen and pushing on where the nerve root should be. And the reason that's so interesting is that is the L3 nerve root on the right side right there. And the L3 nerve root is the thing that seems to be causing you the pain.
Yes.
If we go down a little bit lower, we have the L4-5 level, and we see similar but not as bad stuff. But if we look out in that foramen, we don't see that herniated disc there like we see on the other side. So I believe your problem is a far lateral recess herniation of L3-4, and that really fits with your symptoms. And that's what's wrong.
Yeah.
I couldn't agree more with the way you're approaching this. So this is very likely to get better on its own. There are essentially, even though your MRI report will say you have moderate spinal stenosis, that is not the problem here. This is herniated disc with sciatica, and the herniated disc is about 4% of disc herniations are far lateral, and that's what yours is. Having said that, the treatment matrix for this problem, herniated disc with sciatica, is quite simple. There are two variables that matter. The first is the degree of pain, and the second is whether or not it's causing a neurological deficit. So the degree of pain here is certainly has been severe, brought you to tears with a little bit of walking at one point, but it's getting better, and right now it's bearable. You're not in agonizing pain at the moment.
Right.
If the pain were unbearable, then microdiscectomy would be the appropriate surgical indication. And the surgery for far lateral discs is not like the one for a typical herniated disc. The surgery for a far lateral disc is best done through an endoscope, which is a much shorter, much less invasive operation even than microdiscectomy. It's a 15-minute procedure, and the recovery is a few hours. So very favorable way to get rid of this endoscopic microdisc. And it goes, when you look for people who do it, it's often called PELD. And PELD is an acronym for percutaneous endoscopic lateral discectomy, like far lateral off to the side disc herniation, lateral discectomy. If that's where the disc is, that's where you want to go to get it.
Good.
So, but you don't have unbearable pain. The second possibility, the second thing that goes into the matrix is, do you have a neurological deficit? Because if you do, the longer that goes on, the more likely it is to become permanent. And even though you feel good strength, I want you after this call to try a one-legged squat over a chair on both legs and make sure that hip flexor is as strong on the right as it is on the left, because the L3 is the nerve root to the quad. So do that. The other thing is go upstairs, and when you put your good leg up, and go very slowly and feel what that's like to lift your good leg to the next stair, and then repeat it with the right leg. And feel what that's like to pull on that with that iliopsoas and that quad, and then push yourself up that stair. Make sure those two sides are the same. And if they are, then there is no functional deficit. The numbness that would go with that deficit would be on the inner part of the knee, and the doctor would notice an absence of your right patellar. The knee reflex on the right would be absent compared to the left. So normal knee reflex, normal sensation on the inside of the knee, and strong quad, strong iliopsoas. That means no functional deficit. As long as all those conditions are met, then you have an option. And one option is to get a transforaminal epidural injection just to help control the pain. Doesn't really change the outcome, but may give you some relief as you heal. Or wait it out until either you're done with this and you can't, if you get to 12 weeks and you are where you are today, I would recommend the endoscopic microdiscectomy, because you can't not walk more than 600. You need to get back to normal activities before the end of the year. But if it continues to improve, then let it improve.
Great information. I got a question. So I'll call it the stair step technique you just mentioned.
Mm-hmm.
Let's say that I do notice some difference right now. Am I want to use that as a baseline to measure that again in a week to see if it's getting worse? Or do I say, wait a minute, there's a difference now and I need to take some different action?
It's a good question. It's not that where you are now is the baseline. You have to ask yourself, okay, if I have some weakness now, if I had this amount of weakness permanently, would that be functionally limiting to me? If the answer is no, I just go up the stairs a little more slowly than I normally would, or I hold onto the rail, it's no big deal. If the answer, so that would be, the answer would be no. If the answer is my passion is hiking the Appalachian Trail and I've got to be able to reach the top of those mountains to achieve my greatest version of myself as a human being, and I cannot have any quad weakness, that would be the same amount of weakness in one guy could be functionally limiting, and in another guy, no big deal. So you have to make that determination at this baseline. If this would be permanent, would this really bother you? If the answer is no, it's no. If the answer is yes, it's yes.
Gotcha. That makes sense. That makes sense. Wow, you've answered so many of my questions already there.
That's literally my goal.
Yeah, and I appreciate it so much. Let me give a little second of thought and see if there's anything that I haven't asked that I had on my list here.
Where are you?
I live in Independence, Kentucky, which is about 20 minutes south of Cincinnati, Ohio.
If you did end up in a few weeks wanting to pursue surgery, the probability that the rando orthopedic surgeon assigned to you is the right person is about 2%. So the number of people who do these far lateral endoscopic, percutaneous endoscopic lateral discectomies is very low. And you would have to do a regional search to find somebody near you. I need to get this on my website because I should just do this for everybody so that if you're in this 4% group, you know where to go. But it would be confirming that you have a surgeon, and they might not be super close to you, but it would be worth it to find the right one.
Well, I've got a daughter who's an RN who lives in Boston, and I said, "They got any doctors in Boston?"
Yes, they do.
They got a few, and
They got a few, yeah.
without question, one of the best in the world is probably that treats this is probably there. Okay, so that's good because I was just so far searching on lumbar, and pardon my pronunciation, radiculopathy.
Yeah, let me Radiculopathy.
Right. Yeah. I just can't pronounce big words very well, but I can read them
That's right.
just fine.
Yeah.
So, or lumbar spine. And I need to narrow in a little more on the things that you called out in terms of specialty, it sounds like.
Yeah.
Good. And I look at places like Health Grades, American Board of Orthosurgery, Rate MDs, any particular sites that I should be looking at for these references?
You want to find none of the patient reported outcome rating sites. So that's where patients are entering how they did into a site. None of them are going to talk about where you need to start, which is with the endoscopic capability. It's maybe 1 in 100 orthopedic or neurosurgeons of the spine does the endoscopic approach. And the reason is almost no one needs it. 4% of discs are far lateral, and a small percentage of those go on to need surgery. So to find this, you got to start by finding the surgeon, and then you can check what other patients are saying about them. But it's you got to start with you make up your list with people who do PELD more than 20 times a year, and that's not going to be something you can find on a patient-reported outcome site.
Right. So where do I find that?
One way is to Google spine surgeon PELD, and you'll get there, and then look for the people near you. Start and cast a progressively wider web. Make a list of everyone who does this, and then validate that they really didn't just put it on their website, but rather that they do it regularly. Since you do have a daughter, and by the way, there's nothing better than a nurse daughter to stay with when her dad's having surgery. I mean, that's just a little angelic gift from the gods. So you might want to just start with Boston and do endoscopic spine surgeon Boston and kind of approach it in that way.
Beautiful, beautiful. That is fantastic information. I can do the research, but to find the answers, you got to know the questions to ask, and this helps me tremendously.
Well, if anything pops up, let me know. I'll be happy to help.
Yeah, wonderful. And I think that's all my questions. You've given me some fantastic guidance, and I want to just tell you I appreciate.
It's my pleasure. I wish you the best.
Thanks so much.
It's a bad problem. Hang in there. This is going to be a bad memory, not a permanent issue for you.
Yeah. Well, thank you.
All right. Talk to you soon.
All righty. Bye-bye.
Bye.
I got to do the right mouse.